Okay. The entire mighty but tiny board is present. That means we have a quorum, and the meeting is officially opened. And as always, the first order of business is on the orders of council is the approval of the minutes of the meeting of January 15th. They've been distributed to the board members in advance. Does anybody have a question about them? Is there a motion to approve the minutes? Motion made by Dean, seconded by Lisa, Dr. Newland. Is there any discussion, any additions? Okay, all in favor? Aye. Opposed? Unanimously adopted. And now it's my pleasure to turn the meeting over to our chair and our president and our chief executive officer, Tom Stokes. Tom.
Thank you, Mr. Chairman, and thank you, Chris, for the great sound system. This is much better than the first meeting I had here. Thank you, board, and thank you, our CSEA partners, in seeing us through this difficult situation. We've been having some great dialogue and good discussions, and appreciate you being here and at every meeting that we've had. So I'm going to make a few comments, and then we're going to get into the slide deck real quick. So last board meeting, I talked about many of the findings just within my first 4 days of employment. Cultural assessment is underway. Office of Professionalism is established. Emergency preparedness plans are being developed and drills performed. We've had multiple significant facilities issues, floods in particular, and you'll see some of that in the slide deck. A. Holly Patterson's quality rating has dropped from a 5 to a 4-star, as did its overall rating from a 2 to a 1. We have had some rogue campers and cars being removed from our visitor parking lot. We've heard from the community. The parking lot contract rebid is underway, and the end goal is to either significantly reduce or eliminate the parking fees. Ambulatory care expansion is of focus, both with Harmony in the context of referral management and expansion of hours for our current ambulatory practices. Looking up at Sam. We've assessed on average 30% no-show rates in our ambulatory care practices, as well as regular non-openings of certain practices, which seems to be a daily occurrence. The interim solution is double booking. The longer-term solution needs to be improved access, something the larger hospitals have been criticized for when it comes to caring for the communities that we serve. We're reviewing physician panels, understanding how patients are booked. We're looking to create a front-end interface to the green screen registration computers that we use to check in patients and register patients, and they result in lines and ultimately what end up being hours of wait time before people even get through the door to see a doctor. Seeing the patient demographics, we're assessing the need for more Spanish-speaking physicians and staff. Likewise, from a patient experience perspective, we are assessing dietary needs and even meal planning that is consistent with cultural expectations. We've developed policies and procedures in instances of ICE agents descending upon our facilities. Thank you, Chairman Rabinowitz, for public clarification on that. And we're ensuring that we get paid what is due. And in the context of enhanced rates on our commercial contracts, monitoring medical necessity and other denials, and ensuring accountability for timely closed cases that need to get billed in the first place. So with that said, the slides I'm going to share will focus on 3 areas. 1, financials and projections. 2, volume, access, and referral management. And 3, safety, efficiency, and capital. So with that said, okay. So I'm not going to step on the finance report, which will come, but if you look in the sort of the center gray column under, if the pointer works, actual unaudited for 2025, you'll see down below that we have a $115.9 million loss. About $19 million of that is coming from A. Holly Patterson, about $97 million from NUMIC. And just to make clear, these are unaudited financial statements. We are expecting these numbers to change to the unfavorable. We go through actuarial assessments. There is, estimates that are related to the malpractice insurance captive as well, and we're surely expecting this loss to increase. On the next page, staffing and nursing overtime, I'm looking at Rivka over here. Just want to shout her out, our Chief Nursing Officer. Agency spend is down from when we actually, not before we started this effort, at the beginning of the year in January, down 43%. And overtime spend is down about 48%. So thank you for all the work done there. And the whole team here, absolutely. Goes without saying. So a few things to point out here on the cash flow forecast. Obviously precarious, but I want to make it clear that we are by no means out of the woods. If you look at the January 2026 cash balance, $9.7 million. We're burning about $1.82 million a month. A day, $1.8 million a day. So that's 5 days of cash on hand. As of this morning, thankfully, because of all the state funding that we've received, we're at about 42 days cash. Down to the right, as you go down the slope, these are the projections that were provided by our finance team. About a $20 million net burn per month. You can see when it goes into deficit, clearly before we get to that point, we're going to need additional funding and also working on gap closing measures to enhance revenue and limit expenses. But just to be clear on this, we received $110 million in total VAP-AP and IGT funding. And 25 million of that actually came through in calendar year 2025. So if you think about this, right, we have about $85 million remaining. We have a $167 million budget gap that we're trying to close. It leaves us with about $82 million left that we still need to tackle. Obviously, this is cash. What I'm talking about are finances, but they roughly correlate. And these are the numbers that we're talking about. And we have some massive capital needs ahead of us too, which will hurt us on the cash side, especially if they're unexpected. So moving on to volume access and referral management, just a few things to point out here. And I truly appreciate the engagement and discussions of many of you in this room, the chairs, the administrators, our partners at Harmony Health, the FQHCs, and many others. So the blue line that you see here is for 2024. The orange is 2025. On monthly discharges, which is the upper left, discharges are actually down 10% year over year. Lower left, emergency department is down by 11% year over year. Really what's of concern are significant double-digit declines in the fourth quarter of 2025. October, November, December were 19%, 16%, 14% declines respectively. Going to the upper right, ambulatory visits, not so bad, down 2% year over year, still not great, but not bad. But the real concern here is in the fourth quarter. You see this, again, if the pointer works, the massive drop-off that we're seeing in the fourth quarter of the year. And then deliveries, I thought would be interesting to note that this is a 10-year span. It's not a single, view of 2025, but half the deliveries of what we were once doing a decade ago. And here is partially what's going on.
That's baby deliveries?
That is.
Okay.
Yes, yeah.
Like deliveries
Yes, OB. So upper right, referrals that were scheduled at NUMIC annually in 2025 through Harmony Health. You can see the dip in 2023. We think that has to do with an interface issue, but not quite sure. I haven't gotten answers on that. But the downward trend is certainly of concern. Even more pronounced would be if we actually had Harmony's trend of growth applied against this graph, which is going in the opposite direction. They're actually growing, our referrals are declining. So there's a lot of work that we need to do to sort of mend this relationship, and there's a lot of work that's being done to get all this under control. If you look at the graph down below, this is the year-to-date January 2026, just to give you a sense of where those referrals are coming from or what we're receiving from Harmony in terms of top referred specialties. Going over to the left, taking those January numbers, total referrals going outside of Harmony are 3,900, and the NUMIC referrals that we're getting are 773. So think about why the FQHCs were sort of stood up in the first place, certainly to meet the needs of the community, but from a strategic perspective, it was to make sure that we can grab those referrals and provide continuity of care. Clearly, that's not happening. We have an 80% gap that we need to close here. So there are a few things going on. And if you look at the trend that we're facing on that 20% and where we stood at the end of 2025 with just a little over 11,000 referrals, if we remain on this track, we're going to be below 10,000 referrals, which I can tell you for sure won't be the case because of the efforts that we're putting in place. One of which is that Sam Shutman, who's sitting up there in probably the sixth row, his initial title was VP of Managed Care. He's now the VP of Managed Care plus also Business Development. He has great experience in this area, and I look forward to working with him on this. So I'm going to make a few points before I actually get to this next slide. But as we mentioned, we need more Spanish-speaking providers and staff. Harmony has confirmed that we are losing patients because of this. The language office is reopening and will be much more visible, thanks to board member Amy Flores for pointing that out. Thank you, Amy. We've hired a patient satisfaction director, and we have interim Press Ganey survey reporting that's happening now. So we're not operating blind in terms of how our patients feel about us. Next, also related to some of the work that Sam and Rich and Sam McLaughlin are doing on the finance team, we have insurance contract negotiations that are already underway. Strong double-digit growth being negotiated. We need to go a long way. We've gotten one payer that's nailed down to that regard, but there are many more that are in the hopper, and we're negotiating and we're looping in not only local resources, but engaged with the governor's office to push on issues as that as well. We've also had meetings with department chairs and administrators to expand access, to measure productivity, to reduce unnecessary cancellations, align incentives, and ensure that we're managing referrals. We're also fixing interfaces. We had a revenue cycle meeting last week that was hosted by Rich, in which we found out that in certain areas, we haven't dropped charges since October because the decision was made not to go ahead and renew an interface. So for all the hard work that's happening on the front lines with the patients, we're not able to bill it on the back end. Chances are we'll be able to recoup that. Hopefully we're not beyond any timely filing, deadlines, but we're unpacking that as we go forward. The other thing is we're working on, sort of taking another look at the call center. There are, I believe, 7 individuals in the call center, if I'm not mistaken. My guess, just by looking at the volume, is it probably needs to be double that. So we're looking for metrics like call abandonment rate, and that'll sort of guide us to how we need to expand. So to this particular slide here, we're moving Health First representatives to the lobby area. This is adjacent to Walgreens and across from Starbucks. It's vacant right now, wasted space. So we're really doing this for 2 reasons. One, to increase enrollment and manage Medicare and Medicaid insurance plans. Better to have paying patients than non-paying patients. Obviously, we have some challenges here with, ACA subsidy impacts and all that, but better to try than to not. And then 2, we actually have nearly Rich, correct me if I'm wrong, but a 7% nearly stake in Health First, in which case dividends are distributed. So the more covered lives you have, the greater that dividend ultimately is. So then on to safety, efficiency, and capital. So speaking of access and system interfaces, looking at our electronic medical record in particular, and thanks, Chris, for this background information. You can see here to the left, on the screen is our Eagle system that I described as sort of that green screen, F-key solution to registering patients. 35-plus-year-old technology. We need something new here. Sunrise is sort of the intermediate, but you can see that the timeline for that was sort of the 90s through the 2010s. Epic on the right is what many providers use today, but I will say it's very, very expensive. For an institution like this to go ahead and roll out an Epic, it's about $150 million. So what do we need to do? We're not coming up with $150 million to do something like this. We need to affiliate and think about partnering on these things. So, and I'll say too, this isn't just for, looks or expedience, but it's for patient safety as well. So when you think about things like, medication administration, being able to log, monitor, reminders, all that stuff, it's helpful in real time as well, in a practical standpoint. This is the actual screenshot of the system. Worse than this is that a Holly Patterson is actually still on paper today. We've just made a commitment this week to advance and go with an electronic medical record. So work is commencing there, and I can tell you that Joe Benden the administrator there. Is Joe here? That's right, he is. Thank you. Yeah. So Joe is ecstatic that we're moving forward with that. I'm going to skip a couple. No, actually, we have the right version, Dan. Perfect. So a few things to sort of point out here. I feel like if you look at the upper left, emergence. It's like where's Waldo? Where did the Y go? So you can see it kind of fell down here, but thankfully I think it was Tom's folks actually fixed that at this point. So it's up, but it looks like every other light is off in the dark at least. New canopy, which has actually been enclosed since. That's a great photo. I think Tom Byers actually took that photo. And then you can just see the tattered lettering. I mean, we need to send a message to the community and a strong signal that we're here and we're open for business, right? And it's all about the things that I mentioned in terms of access, but it's about the perception when people drive by our address as well. But that said, we also have some pretty massive infrastructure needs. And, a boss of mine once said that, it's all fine and great when you go ahead and paint the house. Everybody is ecstatic about painting the house, but it's really about fixing the plumbing. And that's a lot of what we need to do here. So next, someone deleted a slide. That was you. You deleted my slide. So the next slide, I'll share with you what was supposed to be up there, and then we'll come to that. So the next slide was the heroics that I've mentioned at previous meetings, multiple meetings, not just the last board meeting, about how the facilities and EVS folks are just dealing with disaster after disaster after disaster. And Tom, you'd appreciate it. I had the water main break weekend before last. I had the rainfall on the floors with about 2 inches of water, which we actually had a video. I'll have to share that in executive session if we have that. And then we took a tour. Is Vito here from Food Services, or Renee? So we took a tour through the food services as well. Their freight elevator to bring up meals to patients is out. So they need to walk all the way around into public areas to get to the freight elevators to bring food up. So the food's cold by the time you get there. And then just about every other refrigerator, stove, whatever is out of business or out of service. So a lot of work that needs to be done. And at the same time, Perry also sent to me this morning pallets and pallets of supplies that we're actually going to be throwing away because they've expired. So obviously there's danger in using expired product, but there's also a lot of waste going on there. So anyway, all that said, I'm going to close on a positive note here. We're advancing with employee recognition and engagement, and in many ways, but here again, thanks to Rivka and the nursing team for really pushing and standing up both the DAISY and IRIS awards for nurses and staff. And while we're discussing recognition, just a shout out to, I think many of you know that we had DOH here for a 3-day survey, and it's a federal patient rights allegation survey that we ended yesterday, thanks to Chris and the quality team and the nursing team and everybody else who was involved, with 0 citations or deficiencies. So I think definitely worthy of a round of applause. And with that, Mr. Chairman, that concludes my report.
Thank you very much. Did they check out the rain in the basement when they were here, or the team? Just 2 points. Number one, nobody reads. Hardly anybody reads The Point in Newsday, and Tom made reference to it and my quote in it. But Newsday reached out to me and wanted to know whether we thought that we were getting consequences in terms of a decrease in patients because of the fear of ICE enforcement. And it's great that we're setting up, and Tom is arranging internally what happens when they get here, and we have to have notice, and we know people have to know where they can go and what they can talk to. But I think a lot of people are being frightened away from us because they think that ICE might come to the hospital. And so I said that to Newsday in this piece. And David Nemiroff, who is the head of Harmony Health, also said the same thing. And he noted that his medical facilities saw a drop in sort of the poorest patients of color also. And my goal in saying this was to try to get the county executive to say out loud what he has said about churches and schools. And he has consistently said that ICE will not go into churches and schools, but he never said they won't go into hospitals or medical facilities. Anyway, when Newsday asked him for a comment on my comment and Nemiroff's comment, saying there's a good chance that ICE fear of ICE is cutting down on people seeking the medical care they need, the county executive finally said that he's not invading except under extraordinary circumstances, or not raiding. He would not raid hospitals or churches or schools. So the goal I had, I mean, at least he's on record as saying he won't come to hospitals. But the downside, it was in this article called, what's it called again? The Point, which, I read, and our PR person reads, and Tom reads, and maybe Dan reads, and that's about it. They have a readership of 4. So we have to get the word out there that the county executive has promised they're not coming to NUMAC. They're not going to raid NUMAC for ICE enforcement. So I thought that was very important. Of course, the county executive immediately blamed everything, nonetheless, on the governor, as you knew would happen. But the main point is we got the quote on the record. And the only other thing I want to add before I call appropriately on Rory Landsman, who is chair of our Committee on Financials, is that all those reds that you saw on the chart in terms of cash, not enough cash, we fully expect the governor to continue her promise that she made to all of us, everybody sitting here, that she would not let us fail and that we will be successful in getting that aid. So don't be, it's frightening, but don't be too frightened by the red, because we fully expect to be helped by the state. On the other hand, we are not the other hand, but note that we are charged with coming up with a long-range plan, which we are already working on by December 2026 to the governor, to present a plan which will have NUMAC be a stable, financial, and yet still safety net hospital for the communities that we serve. Because you can't forever count on hundreds of millions of dollars from the state. I wish we could, but I think we can't, and we have to help ourselves in every way. And I know Tom Stokes and his team have already begun making improvements in revenue and cutting down on expenses and so on. So we will get help, but that doesn't excuse us from either in the short term or long term developing a way not to, as Tom put it, burn so much money every day. And now let me turn it over. We have a very small board, but they're incredibly devoted and committed to the welfare of NUMAC and Ahali and our clinics. And they work very, very hard. They get a lot of assignments between the 7 people on not just as you see here, but on committees and so on. And the Finance Committee met and worked today, and they do a great job. And here's the chair of the Finance Committee to fill us in on what happened. Rory?
Thank you, Stu. Good afternoon, everyone. Just a brief report on the meeting of the Finance Committee of last week. We got a presentation from Rich Miller and his team, which we appreciate, basically focused on the 2025 unaudited financials. How did we do in 2025? There was a $22 million improvement from what our projections were back in September of 2025 as to how we would close out the year. And a lot of the big picture items were in Tom's presentation, so I won't reiterate them. Just a couple of things that I thought the board and the public would be interested in. Thanks to the hard work of folks here, an attempt by FEMA to claw back over $11 million in FEMA aid was defeated, and so that is money that is going to stay at NUMIC. On the downside, the consequence of what Tom and Stu were talking about, of people being afraid to come to the emergency room, come to get care because of their immigration status, obviously, first and foremost, there's a human tragedy behind that, but it also has a financial impact on the hospital. And as visits to the emergency room decline, it has an impact on our revenue, which the hospital has got to figure out how to manage. One thing about that what I call the scary chart, that shows our cash balance declining precipitously, that does assume that we make our full $9.7 million a month payment to NYSHIP for employees' health premiums, which is our goal and is our expectation. But as Stu said, that depends on continued support from the state. So if that state support is not forthcoming, then we'll make adjustments into our monthly payments, and that chart will be less scary. But that's not our expectation. So we came away from the Finance Committee meeting with continued confidence in the finance team and the management team, and that the hospital is moving in the right direction. That's my report.
Okay, thank you, Rory. Okay, now is the part I'm always nervous about because nobody ever registers for this, but it's the public comment question time period, and we welcome questions or comments from the audience. Once again, please try not to argue, just ask questions. I'm trained in the law, and I just can't shut up when arguments start. So just ask questions. And don't take too long in case we're swamped, as usual. Kidding. With a lot of questions and comments. So does anybody from the audience want to ask a question? And please direct it to me, and if it's appropriate to ask somebody else to answer, or if it's too hot for me to handle, I'll refer it to somebody else. Yes.
I'll ask a question. So good afternoon to the board and to CEO Tom Stokes. So we have been having conversation. I'm Shakira Settles. I'm the local 831 president. So we have been having open communication and conversations with the new CEO, so we appreciate those monthly meetings that we've been having. However, as you guys are all aware, we have been at a contract since December 31st, 2022. So what we want to know, and when I say we, I mean all the employees who are members of the union, would like to know, what are the expectations of us going back to the table?
Well, I'll take a shot, then I'll give it to Tom. And I'm just saying we're well aware and unhappy about the fact that you guys are working since 2022 without a current contract. And we have already said to the state, various members of us, Tom has said it and I've said it, that it's an issue which has to be addressed quickly. And it will be. It's a very complicated issue. It's a funding issue. It's who can be affected and not affected by our agreement with our union as opposed to the state union and others. So we will get to it. But right now, we are at the point where we're trying to plug holes and make sure that we have enough money from the state and so on, and a long-range plan to exist. So yes, we will get to it. I wish I could be, clearer as to when we will get to it, but it is a high priority of ours. Maybe Tom can fill in more.
Yep. Would love to. Thank you. Yeah, and look, we've had multiple conversations. I think it's unconscionable that the CSEA has gone 3 years without a contract. And there is, what's that?
4 years.
It's
3 years, 4
at this point,
Januaries.
right? I think we're in our 4th year, right? Yeah. So, anyway, I think there is a lot of work we need to do. This is top of my mind, clearly. I think that there's a lot more we need to do than just, do a generic redo on a collective bargaining agreement. I mean, there are things, as I've spoken with many of you here, we need to run this like a business. We need to think about what the ROI is. Sometimes you need to put money into it to ultimately make money, to make it solvent. That's where we are. And I think that, the more we think like that, the better off collectively we'll be. And without getting into it, I'll just say that, it has been brought to my attention that we have various starting salaries, for instance, that are way, way below market. And I'll throw it out there. Nursing, for instance. A nurse who comes in at $85,000 a year into NUMIC spends about 6 months here and then goes on to somewhere else. We're a training ground. We're not a long-term prospect for that individual. As great as the benefits may be, they're not thinking about that stage of life. I can tell you where I came from, the starting salary is about $115,000, $120,000. I don't even know that we can get near that. But these are the things that we need to collectively work through and think through. So, the fact of the matter is not too many people, you all get this, but the general public doesn't understand when you hear about no contract for 3.25 years, we're in our 4th year, that, they think, well, there are steps and there are other things that you get, but the reality is you might be top of grade, right? So you're not getting those. Zero COLA in a period where inflation has hit record highs is difficult to deal with. So I would ask for everybody's patience and dialogue as we go through this, and let's communicate what timing makes the most sense and what things we can do to first make sure that we are going to be a solvent entity. And as we move forward with our strategic visioning plan that we're going to be talking about in executive session, all of this is going to come together. So thank you.
And, not to beat a dead horse, but to mention again that somebody mentioned that the monthly payment to NYSHIP for employee benefits is extremely high. Is not irrational if you give it, certainly. I mean, I wish we could all do that. All have those kinds of benefits, rich benefits. Maybe there's a trade-off someplace between increases in salary and maybe a small and gradual decrease in the institution's liability for long-term benefits. But that's why I say it's complicated. No decisions have been made about that yet. But I think, to be open and transparent about it, I think it's 60% of every dollar we spend in salaries is also costs us, 60% of that costs us in benefits. And that is a very, so if we give a dollar raise, it costs us 60 cents so in benefits. So it's really $1.60. And it's very difficult. It's very difficult to balance that out in the long run. But what we can promise you is, A, importance. It's key to us to keep our employees well paid and happy and loyal, because if we don't all pull together, we're never going to get where we want to get. And B, as Tom said, it has already begun dialogue. We're not doing anything by fiat without letting you talk to us about anything. I promise you those two things. Okay, any other questions? Sir? That, my friend, is the question. Well, that's well put. Well put. You know what? It may be impossible, and it may be that, the state has to wake up and the federal government has to wake up and understand that supporting safety net hospitals like NUMAC is part of a social service welfare plan that they need to plan on funding, in the long run every year, the way they would fund, any other social welfare benefit. But they have to, we have to reduce the amount that we're asking for that to be happening. And you've got you've got a smart CEO, you've got a smart board who's committed to new ideas, and we're going to explore every way to increase revenue and decrease our expenses, including things like monetizing no decisions have been made. We're just getting to it. There's a lot of real estate we don't really use productively and does not produce income. And it's a complicated thing to monetize that in dealing with other governmental entities and so on. But I never think anything's impossible. That's hardly ever until I'm beaten to death, and I'm not there yet. So I think that, we're going to try to increase that. We're going to try to figure out what we really need to do, and if we're doing something, we're providing a service that the community is not using and doesn't need, and we are spending a lot of money on that, we need to do something about that. Maybe we're not investing enough in certain departments, as Tom mentioned, that the community desperately needs. So we're looking at the whole picture. Can we break even? I don't know. We can come much closer to breaking even than we are now. And I, for one, am optimistic that if we do that and come close to that, that the state will come to realize, the governor owns us. She took us under her wing. And I'm confident that we can come up with a plan that's sustainable in the long run. Again, break even, I don't know, but not $200 million a year of government funding to make it happen. So, great question. Anything else? Yes, ma'am. That is a small suggestion of tremendous merit. So we will make sure that happens. So you don't have to sit in your chairs waiting for us to come back. We have no idea. We may be small, but we talk a lot. So, we have no idea when we're coming back. If we did, we would say to you, we're coming back at such and such a time, but we just don't know. But there's no problem in announcing it, 10 minutes before we reconvene. Very good suggestion. Visionaries don't think of stuff like that. That's really good. A second question. This is your last question for today. Who are you, by the way?
I'm Dr. Berman, Dean Berman, ear, nose, and throat.
Oh, hi. That's not one of my illnesses, so I can't use you. Go ahead.
If you get a bloody nose, you look for me or my colleague.
Okay.
The question is, in private practice, I was sitting at billing, and my quotas and billing service was changing the numbers and upgrading, et cetera, et cetera. Is there a way to have coding in there? Is that better collection?
Oh, there absolutely, is a way to do that. So let me start with your last question. I think Stu summed it up perfectly in that we shouldn't be losing what we're losing. There's plenty of opportunity. You heard some of it in my presentation. Revenue cycle is a huge part of that. Coding is a huge part of that. When you think of the E&M codes in particular and the various levels, there are millions of dollars there. I don't care what your payer mix is. So this is something that we're working through and the finance team is already focused on, and we'll continue to assess and in pretty rapid order actually have results to report out.
Okay. That's two good questions. You should rest while you're ahead. Anybody else? Want to be a straight person, straight man, straight woman for me? No. Okay. All right. Do I have to read something now, Dan?
Yes.
What? Okay, I have to read something. Okay. I appreciate all the speakers. I didn't have to read that. I will now entertain a motion for the directors to conduct an executive session pursuant to Public Officers Law, Section 105 and Section 3402-10B, for the purposes of considering matters leading to the appointment and employment, promotion, demotion, discipline, suspension, dismissal, execution, no, it doesn't say that, or removal of a particular person for the proposed acquisition, sale or lease of real property, or the proposed acquisition of securities, or sale or exchange of securities held by such public body that such discussion publicly would substantially affect the value thereof, for the purpose of considering strategic marketing plans, analyses, evaluation, and pricing strategies of the corporation relating to the business development, which, if disclosed, would be likely to injure the competitive position of the corporation. And despite my admiration for Dan, if the law requires that I read that every time, in the famous words of a judge, the law is an ass. But anyway, is there a motion? Is there a motion to enter into executive session for only the purposes that I've read?
I'll make a motion. Flores?
Motion by Amy Flores, second by Dean. You're not doing your usual seconds. Second by Dean. All in favor? All unanimously in favor. You will hear an announcement when we return. Thank you very much for your attention. Here he is. Do I have to say anything but here we are in open session? No. Okay. It says the time now is 6:52. Hey, I got that right. And we're reconvening an open session. I don't have a report, so no chairman's report. There's been enough time in talking today. So I want to turn now to an agenda item, which is the appointment of a strategic planning consultant. And as we previously mentioned, the board is required by statute to produce a long-term strategic plan for the governor's office by December 1st, 2026. And less than a year. It's scary how short a time it is. And in order to assist with this report, the board properly decided to hire one or more strategic planning consultants. It's what everybody expected we would do, so they could do numbers and the groundwork and so on and so forth while everybody else is trying to run the hospital. Although we are actively participating in the planning process. So on December 10th of 2025, we released an RFP, a request for proposals, to identify one or more qualified consulting firms who demonstrated expertise in strategic planning, healthcare transformation, and organizational performance improvement for complex health systems. By January 5th, we received 8 different proposals, 8 different companies. We evaluated them based on experience with public sector healthcare delivery, financial distress and liquidity pressures, regulatory oversight and state involvement, public and political pressure, and organizational size and complexity and scale. In other words, we determined whether they'd be proper for us because we have all of those. So we identified 3 finalists. And we engaged with each of the finalists with a full committee consisting of course, our CEO and other members of the C-suite team and myself representing the board. And they made presentations, we asked questions. And at the end of it, we all reached the same conclusion, which is that we recommend that our CEO enter into contract negotiations, seeing if we could get a price break, with Huron Consulting, Huron. And they're incredibly, as we discussed, competent, experienced. They have coverage in every possible area that we have to look into, going from financials to data to revenue cycles to they understand the importance of involving the community every step of the way, involving our legislators who support us and those who don't, and the members of the board. And we unanimously recommended to give authority to our CEO to enter into a contract and negotiate the final terms with Huron and company. But now I'd like us to take another vote on that, if we can get a motion to essentially approve that we hire Huron if our CEO can work out the final contract.
We did that.
We did that. Okay.
You were just about.
You
wanted a second one?
Okay, so we already did that. We could do it again if you really want to be sure that we raised our hands. But that's one announcement. And you'll all be getting to know Huron, because this will be an inclusive process and not an exclusionary one. And then the other two items on the agenda are more items that they're not ministerial because they're very important, but they fall more within legal and quality measures, which means that I'm going to ask Dan Lindenberg, our general counsel. Do you know Dan? Look how much weight he lost since he became general counsel. Dan, will you read the resolution?
Sure. 73 to 82. That's it? Wow. That was a long resolution. Okay. The Board of Directors of Nassau Healthcare Corporation must approve certain contracts entered into by the corporation for the procurement of hospital and professional services. The Board of Directors now deems it advisable in the best interest of the corporation to approve the following contracts for the term and amounts referenced in each resolution. Now, therefore, be it resolved that the NHCC Board of Directors authorizes the chairperson, president/CEO, or their designee to negotiate and execute the following contracts or amendments set forth in 73 to 82 -2026.
Do you want to have a separate vote on the contracts, or?
We're not there yet.
You're not through yet?
No, hold on.
Sounded like you were.
I'm just reading on here. That's different from the script I'm used to. Your board packet includes a list of contracts entered. Oh, I don't know what I did here. Is there a motion to approve those? Motion approved. Anyways, these were the contracts. So the purpose of these contracts are contracts that are in excess of $250,000 require board approval. Anything, and all of you know this, anything less than $250,000 require the approval of the Legal and Audit Committee with recommendation to the board. We did receive the recommendations from the Legal and Audit Committee, and now we're here asking for the approval from the board for the rest.
Yes, and I think, I certainly went over in fashion the number of contracts, and nothing seemed inappropriate in any way. So there's a motion to approve? Somebody made that motion? Jason? And a second? Second? Okay. Any discussion? All in favor? Aye. All opposed? Okay, approved unanimously. Now you can go on to the Credentials Committee.
So there's a credentialing packet. It was distributed prior to the meeting. It was included in your meeting materials. This packet is recommended for approval by both the Hospital's Credentials Committee and the Medical and Professional Affairs Committee of this board at their most recent meeting, which took place earlier this afternoon. I'd like the chair.
Yes, and just to add how impressed I am by the process that we go through and the work of Perry and her team on the credentials, and being very careful about making decisions on very important but sensitive issues. So do I hear a motion to approve the credentialing packet was given to everybody on the board, so do I hear a motion to approve that?
What was the resolution number?
Say that again?
Is it 83? No.
Thank God, that makes all the difference. So is there a motion? I'm sorry I make fun of you. I'm a lawyer
I'm
myself,
okay. I can take it.
So moved. And is there a second? Second. All in favor? Aye. Opposed? Unanimous. And any further business? Hearing none? Is there a motion to adjourn? So moved. Second. All in favor? Thank you all very much for coming and staying. It's the holidays over. President's Week, but happy Ramadan. And I'm sorry it's Ash Wednesday if that's appropriate or whatever.